she did a pretty big workout, of course, without doing it. She also had 2 episodes of pre-syncope, and had 1 episode of diarrhea last week, only around 3 or 4 episodes, lasted 1 day. So that's the kind of the chief complaint. 41-year-old female with weakness without any clear explanation. So the other thing on her review systems was positive for pretty bad fatigue, malaise as well, but she did not report any fevers, any weight loss, or any chills. She did have also blurry vision. She had myalgias, no joint pains, and of course, upper and lower extremity weakness. Digging into more review systems, especially of her past medical history that we're going to talk a little bit in a while. She did have every now and then, like every once every 3 or 4 months, she will complain about dryness on her eyes and her mouth.
Awesome, Pablo. This is a great place to get started. Just kind of to give us a little anchor, could you maybe share kind of just briefly what the consult question was?
They consult us because the page was, we are unable to treat her hypokalemia and her hypophosphatemia. Like, it's resistant to medical therapy.
Okay, Andy, kind of as a nephrologist, I know there's kind of minimal information here, but what are some of the things that would be going through your mind with this information?
Well, I mean, for starters, she's young. I'd like to know what part of the world is she from? That might kind of help a little bit. But hypokalemia, the differential is vast. It can go anywhere from medications to, could be illness, could be genetic disorders. I mean, we don't know her vitals yet, so that's a whole new bag of worms too. But then you mentioned that she had dry mouth and dry eye, so that might be a little curveball. I don't know. I'm kind of excited. This can literally go in any way. And then my first question is, what's the magnesium? Because, you know, hypokalemia, that's always what you ask. But outside of that, I'm perplexed. I mean, it could be anything at this point.
Right. Very fascinating differential.
Yep. When you hear like dry eyes and dry mouth, I know that this is kind of a little bit of possible room overlap, but is there any questions that you find helpful? Because a lot of people get a little bit of a dry mouth or a little bit of dry eyes, but to maybe differentiate like an autoimmune cause from just a slightly dry mouth.
Are you asking me, or are we talking to generally, or who?
Yeah, if you kind of have any thoughts that come to mind, and then feel free if anyone in the chat has some experience with this too.
I mean, for me, I usually start with, you know, just kind of the common things like time of the year, things like that. You know, were they outside? Were they not? Are they taking any antihistamines? How long? Yada, yada. And then if all that seems to be relatively, you know, not, I guess, not the main or upfront issue, then I kind of dive down a little bit more. I mean, 41-year-old, you know, dry eyes. I mean, you always got to ask if they had any surgical procedures like LASIK. That's a common thing. And then you get into your little autoimmune stuff. You know, could they possibly have, you know, Zika syndrome? Could they have, you know, like what else could be going on? Are there any other systemic manifestations? So you go down that list. So family history. So, I mean, that's kind of the way I would approach it. I've just seen that these tend to be relatively rare and there's usually a more common explanation, but I've had my share of surprises and, you know, these do pop up. So.
And if they're gonna pop up, they're gonna pop up on VMR.
Yeah, you know, why wouldn't they?
Awesome. Pablo, would you give us some more information?
Yes, sure. So she didn't have any really significant past medical history. Really, she doesn't see any doctors on her life. The only surgeries that she had were 2 C-sections, like were uncomplicated pregnancies as well. She does not use any medications, either prescribed or over the counters. Her family history, there's diabetes on her mother's side, hypertension on her father's side, but nothing really autoimmune on her family, no cancer, nothing like that. Social history, she doesn't use any type of tobacco products, doesn't drink alcohol, does any drugs. She's not allergic to any medications, and she stays at home. She's a stay-at-home mom. The other thing is that she's from Mexico. I think Andy was asking about where she's from.
Any herbal supplements?
No.
Okay.
Time in the US, someone's asking time in the US for her. I think this was around February. Oh, time in the US that she has been, I don't know, like 25 years or so, maybe more.
Okay.
Okay. Anything else? Any other questions you might have or something you would like to know so far?
So did she have any past episodes that kind of point to issues with hypokalemia? Like this is her first ever complaint of anything. Like she never had even minor weakness in the past or nothing like that. Okay.
No.
All right. And then I guess since we're going through history and questions, I mean, any large carbohydrate meals, or you said she had strenuous exercise the night before or the day before?
No, she felt like she did a pretty large workout, but she didn't. She was just having myalgia and was feeling very, very tired.
All right. And the first time this happened 2 days, and the dry eyes, dry mouth were a couple months, we said?
Yeah, they were not associated with these symptoms, but she mentioned that she might have some episodes of dry mouth and dry eyes. Okay. Last episode was around like maybe 5 or 6 months.
All right. Okay. Huh.
Oh, sorry, I don't know.
You were muted.
Of course. Would you explain your thought process asking about the large carbohydrate meals, exercise, kind of what you're thinking of on your differential?
Sure. So, I mean, typically I see, you know, this is seen more in, well, I guess it really doesn't matter geographically. I mean, it can be seen in a lot of populations, but periodic paralysis tends to sneak up there every so often. And if I'm not mistaken, it's a disorder in one of the calcium channels in the cells. And what you have is anything that leads to, I guess, an intense insulin response will drive potassium into the cell, and you end up having this profound hypokalemic episode, but it tends to be recurrent. And if it's genetic, it tends to pop up in like your 20s, 30s, sometimes a little bit sooner. And usually you have multiple episodes, and over time, the more episodes you have, the more residual weakness you start developing. So climbing stairs become difficult, reaching up over your head becomes difficult, but these tends to be exacerbated by, you know, a large carbohydrate meal typically is the buzzword. Strenuous exercise is another one that can predispose it. So it's just kind of, you know, just given her age, nothing else really going on, just worth a shot.
And then I know it wasn't the case in this case, since there were no medications or herbals or anything like that, but in a case of hypokalemia and hypophosphatemia, are there any specific medications that you would be kind of looking specifically for on the medication list?
So when I first hear hypophosphatemia, it sounds like a dumping disorder. And I start thinking of proximal tubular dysfunction. So like a Fanconi's type. I mean, this is really jumping ahead, but that's the first thing that pops into my head. And typically you see hypo everything in that case. And medication wise, anything that typically affects the proximal tubule. So some of the antivirals that are out there, certain antibiotics could be, of issue if she was ever hospitalized and, got anything a little bit more potent. So like amphotericin can do it too. But usually it's some of the VMRs like tenofovir has been known to do it. You can have topiramate can affect, that's usually more of a metabolic acidosis and much more less of a hypophosphatemia type aspect. But one thing we didn't ask is when we saw her for the HPI, what did she look like? Was she cachectic? Was she well nourished? I mean, are we dealing with someone who might be, bulimic and anorexic?
Right. Good question. Very good question. Yes, but her BMI was like 25, 26.
Okay.
She didn't have any stigma of bulimia or anorexia.
Okay.
Should we go to the vitals, or is there any other question you have?
Yeah, I'm interested in the vitals.
Okay. She was afebrile. Her heart rate and her blood pressure. So she did have orthostatics on the ED, and this was fortunately before getting any fluids. So there was orthostasis on her at the time of her evaluation. Then her respiratory pattern was pretty okay. Her breathing was 18 per minute, and her oxygenation was 98% in the bone marrow. As I said, her physical exam, she didn't have any signs on her mucosas of surreal vomiting or anything like that. Her paroles were normal size. There was no increased size there. She didn't have any lymphadenopathy. She was a little bit tachycardic when we saw her, no murmurs or anything like that. Her lung exam was pretty remarkable, as well as her abdominal exam, and she did have decreased strength on her lower extremities. Her reflexes, though, were normal, right? And that's something important, as Andy was saying. When you have hypokalemic paralysis, usually your reflexes are gone. And she didn't have any rashes or anything like that, or any dryness on the skin.
Okay.
And her neuro exam, the strength was documented as 3/5 of muscle strength.
3/5 normal reflexes. Okay.
Yeah.
And no weird joint swellings or anything? No.
No.
Okay.
Although you
No
might have
oral
shared this
ulcers?
Sorry?
Any aphthous ulcers?
No. No, and her teeth were okay as well. Sorry, we're having a question.
Oh, I was going to ask about dentition and if there were any abnormalities.
Yeah, no infections, no dryness, nothing like that. Someone's asking if her sensitivity was compromised, but no, her sensation was okay.
Sonia, I don't know if you're here, but if you're in a place where you can unmute yourself, just because I know that I believe you're still a rheumatology fellow, but just kind of like if there's anything, if you're thinking about like possible Sjögren syndrome, if there's anything you look for on the physical exam.
If you guys are okay with the sound of sizzling dinner.
It adds to the ambiance.
The thing that we usually look for on exam is really objective evidence of dryness. So like we'll have patients open their mouths and we actually look to see if they have any salivary pool under their tongue. So if somebody opens their mouth, first of all, like you can see a whole bunch of fake teeth, which sometimes can be helpful. Like if they've had their teeth replaced or if they've had implants, that can be a hint to you that they have at least poor dentition, if not necessarily from dry mouth. But also if they have just no salivary pool, oftentimes you lose the papillae on the tongue too. So that can be a hint at a very dry mouth. And very, very rarely we'll actually get parotitis or, you know, the parotids are either swollen or tender or something like that, but that doesn't happen very commonly. And then the dry eyes, we often actually send them to ophtho for an objective evaluation. We ask our ophthalmology colleagues to do a Schirmer's test to quantify how much tear production they have. So those are the two biggies. But then if we're actually, you know, either if somebody has a known diagnosis or if we're very suspicious, we'll ask about extraglandular manifestations too. So our favorite is to look for synovitis, but we also listen to the lungs because Sjögren's can come with ILD. And we do as good a neuro exam as we can without being neurologists to look for either sensory deficits or a mononeuritis multiplex because Sjögren's can go to peripheral or central nervous system. I think those are the biggies. I'm probably forgetting a ton.
That was awesome. Thank you so much. Pablo and Andy, before we move on, any kind of, if y'all are doing an evaluation in this case, anything specifically that y'all would be looking at? I know Pablo mentioned that.
Just muted.
Yeah, you're cutting in and out.
Oh, I don't know why it's doing that. I was just going to ask, anything else that you like y'all would be looking for on physical exam or like with hypokalemia or hypophosphatemia before we move on to get to the labs?
So for me, it would just be to just document true weakness. I mean, a lot of times, you know, some folks claim they're weak, but in reality, they have, you know, perfectly normal strength, normal reflexes. So anything that would contribute to, you know, I would say complementary electrolyte abnormalities. So reflexes, hyperreflexive, or, you know, no reflexes. Is their strength actually decreased, or are they just saying it's decreased? Is it limb girdle or is it more peripheral? And it can kind of help you come up with a differential in that sense. I mean, from this one so far, with mouth looks fine, no ulcers, you know,
Her BMI as well.
her BMI, yeah, I mean, it could be bulimia still. I mean, maybe she's like new onset and she's never done it before kind of thing, but, you know, I'm looking more towards, you know, eliminating some like the other things of hypokalemia. Like, could it be a secondary hypertension kind of thing? Doesn't look like it. She was orthostatic. Sounds like the opposite. So, you know, I think from my perspective, I like to see the numbers more so. And that's what I'm looking forward to next.
Okay, so let's go to the numbers. Her sodium was 134. Her potassium was 2.8. Her chloride was 110. Her bicarb was 15. Her BUN was 16. Her creatinine was 1.4 without any baseline from before. Her glucose, sometimes forgotten in the BMP, was 90. Her calcium, let's see real quick, was within normal limits, was I think 8.5, 8.6, yep. Her phos was undetectable.
Wow.
And her magnesium was 2.8. Then her both AST and ALT were within normal limits. Her alphos as well, not within normal limits, was like 60, 65. Her bilirubins as well within normal limits. Her albumin was 3.8, and her total proteins were 9.5.
Wow. So we basically have someone with a normal anion gap, hypokalemia, and hypophosphatemia. Nice. Someone asked about myeloma and all that. Yeah, I mean, we'll see based on the urine analysis. And if we do a urine protein creatinine ratio, her albumin looks fine. If her UA is negative for protein and her protein creatinine ratio is high, that would point to a myeloma. Myelomas also point to a lower anion gap, typically, because you have all the extra proteins adding to the negative charge. So her anion gap was 9, I think, if I did the math right. So I would say less likely. Doesn't mean it's not, but right off the bat, less likely. Protein gap is there. That's interesting, though.
Right. Yep.
So we'll see. I'm intrigued.
What are some of the differentials? Kind of mentioned multiple myeloma. You know, we have a presumed like non-anion gap metabolic acidosis with hypo K and then hypo phos. So, kind of what are the things going through your mind with that information?
For myself, so I mean, right off the bat, non-anion gap acidosis. I mean, we don't have a urine anion gap, so you know she had a little bit of diarrhea, but I'd be interested to see if it's positive or negative. But I'm going to assume, kind of based on what we're seeing in the pattern, that it's going to be renal based. So all the paraproteinemias, Waldenstrom's, multiple myeloma, all that affects the proximal tubule. So you'll have a type 2 RTA picture. Type 1 tends to be more like mixed connective tissue disease, sarcoid, Sjögren's, things like that. So I'm already boxing her with a proximal tubular dysfunction. We do have this protein gap. We'll see what happens with more of the labs. She's young, no weight loss, no nothing like that, no night sweats that we talked about. Now I'm kind of revisiting the HPI, making sure we didn't miss anything. But I'm assuming no night sweats, no B-type symptoms, right? Okay.
Mm-hmm.
So it could be. I mean, it's definitely pointing to a proximal tubular dysfunction at this point.
Right. Just to complete the initial labs, her hemoglobin was 12.5. Her white count was 7. Her platelets were 250. So everything was pretty within the limits on her CBC. And again, there's no previous records.
Mm-hmm.
Pablo, would you share? I'm sure you're going to give us more urine studies and some lab studies as well. But if we were calling you with this consult, like what are kind of, when you were hearing this information, what are the initial things that you would ask us to like order right off the bat?
Well, definitely I will be scared that someone has been given, DD gave her like, I think 3 doses of IV potassium. Sorry, I think I forgot to mention that. And she was still hypokalemic. She was not responding. Right? So my first thought would be that she's losing potassium right through her kidneys, probably. And as Andy's saying, I'll probably think about a tubular dysfunction in the association of hypophosphatemia and hypokalemia, right? And very likely this patient, my first act was call the ICU because she's not responding and she's becoming hypokalemic. And, you know, this can cause tachyarrhythmias and that, and she can die, right? So put a central line and give her potassium there and also phosphorus. And also, right, phosphorus, an undetectable phosphorus is pretty scary, right? That can cause diaphragmatic paralysis and the patient can stop breathing. Right? So she needs an intensive care monitoring, definitely. But yeah, that was my initial thought. Call the ICU, and we'll see what the urinalysis shows.
Awesome. We'd love more information, but I always think it's helpful to hear like kind of what as a consultant would be the first
Yeah.
thing that you would ask for.
Yeah, sorry? I didn't get that last part.
She was saying she's interested to hear what the consultant would ask for right off the bat.
Oh, yeah.
Yeah, yeah.
The other thing that I asked for was a BBG to see what her pH was in relation to her acid status, right? So her a BBG was done, and she had a pH of 7.24. And her bicarbonate was 15, which pretty correlate with a BMP. The other thing I did order, I don't want to take on this explanation, was a uric acid, but that we can go. We can talk about that in a little bit. They didn't get an ABG because someone, Josh Morris, is asking if ABG was done. That's a pretty good point. I did ask for that, but she was a pretty hard stick, so they didn't an ABG. But I was pretty satisfied with the BBG on her. So her urinalysis. Yes, I agree with Dr. Center. I follow you on Twitter. A BBG is pretty good enough here. I agree on that. Andy, what would you like to know in the urinalysis, the UA and the dipstick?
Oh, well, the first thing I want to see, she doesn't have a history of diabetes. Is she spilling glucose? Because that would be the hook, line, and sinker for a proximal tubule dumping syndrome. So that would be the first thing I would look at. And then everything else would probably fall into place. I just want to see, I mean, I'm assuming it's going to be bland otherwise, but I want to see if there's glucosuria.
Yes, she had a pretty remarkable glucosuria of 300. There was minimal protein, no RBs, no CAS, no hematuria, no nitrates, no bilirubins, nothing like that. So the only thing was remarkable was her glucosuria.
Mm-hmm. All right, now I want to know what the uric acid is, because that might be the nail in the coffin.
1.3.
Like exciting. It's like I'm at the horse races. Like, come on. Oh.
Yeah. And would you explain why, like, kind of the rationale behind the uric acid in this case?
The hypouricemia. So hypouricemia is reabsorbed in the proximal tubule, and it's one of those things that you can use for a couple of things. One being if someone has an AKI and you want to see what the tubulars are doing, you can see if there's any increased reabsorption or not. And then in this case, it definitely points to a dysfunction, and that's kind of what I was hoping to see. I mean, we have someone with hypokalemia. We're not recycling any bicarb. We're not reabsorbing any phosphorus, which I believe like 60% of the phosphorus is reabsorbed in the proximal tubule, maybe up to 80 if I'm not mistaken. Uric acid is in the proximal tubule, then you have your SGL receptors up there too, so glucose is. So with all those being low, I mean, we're looking at a proximal tubule issue. Now the question is why? Hopefully that answered your question.
It did. Thank you so much.
Then the other thing I also asked was, because I actually had seen a hypokalemic periodic paralysis when I was a resident, and in that scenario, the TSH levels were undetectable. Her TSH was within normal limits. I think it was 1.5 or so.
Did you do a urine protein creatinine ratio?
Yeah, we did get that. Which was, let me tell you in a little bit. When I go into the electrolytes, I'll tell you about that. Then her ESR was 71, so elevated. Her C-reactive protein was 13.
Little inflamed.
Then the other marker that I ordered was a beta-2 microglobulin blood, which was also elevated, was 2.9. Sorry, in urine. beta-2 was in urine. Then her UPC didn't show too much protein leaking. It was below 300.
Okay. So someone asked about the difference between urine albumin creatinine ratio versus a protein creatinine ratio. And to me, that would, so if you do a urine protein creatinine ratio, your albumin should be roughly, give or take, a little fudge factor, about half of that. So if, let's say, their, urine protein creatinine ratios like a gram, then their albumin should be between 400 to 600, give or take. So if you don't see a lot of albumin, then to me, it's not a glomerular issue, and we're looking at much more of a tubular impact. So we're looking at paraproteinemias and so forth. The other thing is the UA. UA is only test for albumin. So considering there's minimal protein, we had this protein gap. I'm interested to know what the urine protein was. So if the urine protein was elevated and we have a protein gap and almost no protein on the UA, then we're looking at more of the paraproteinemia kind of cause. So hopefully that answers that question. And then,
okay.
Oh, sorry. And then I was just looking at the VBG bit, and VBGs are actually really cool. I don't know if you're going to talk about this later, but I mean, it was probably not even a major point in this talk, but if you're in a pinch, VBGs are so much easier to get than ABGs, and they give you so much information. I mean, the bicarb is pretty much the same. The CO2 is only like 0.4 off, if I'm not mistaken. So you can get pretty accurate levels minus the O2 sats just by doing a VBG, and it's quick and it's easy. You can get it from a peripheral. So I love doing those. I think they're quick and easy and underutilized.
Right. That's why I didn't push for an ABG with those values, to be honest. So, okay. So what else would you like to know?
My mind was like just racing. The beta microglobulin, what did you say about that?
What's elevated in urine? Yeah.
It was, okay. Sorry, guys.
Okay, so then, of course, we did order for urine electrolytes. Urine potassium was 13. Urine chloride was 41. Urine sodium was 34. Urine pH was 7. And her urine gap will be revealed now.
Will be revealed.
Or Andy, would y'all walk us through the urine anion gap, kind of, and what the significance is of that and how to interpret it?
Oh yeah, absolutely. So I think the urine anion gap has come under some scrutiny, but I think it's still a huge tool and it does help a lot. So basically what you're looking at, and one of my mentors, and I'm assuming it's one of Pablo's mentors too, Dan Bhatia, who's at my previous institution, so Pablo's institution, wrote one of the papers on urine anion gap and why we should be using it. And it's great. It's a great paper, really heavy. But I asked him this too, and I'll get to it in a second. But basically what you're looking at is you're looking to see if the kidney is able to excrete acid. So ideally, if you do have a metabolic acidosis, right, and you're looking at a non-gap, the vast majority will be grouped into two categories. One's going to be a GI cause, meaning you're probably losing your bicarbonate, and two is going to be a renal cause, meaning you're probably not secreting any hydrogen or not losing any hydrogen. So what I always tend to remember is when you look at the urine lights, if it's negative, then in a metabolic acidotic state, then it's the gut's fault and the kidney's doing what it can. Meaning that when you do your pluses versus your minuses, so your sodium plus your potassium, and subtract it from your chloride, you should have a higher chloride than the sum of your sodium potassium, implying that the kidney is excreting hydrogen. Now, my question was, what you're measuring is you're indirectly measuring the ammonium that's being secreted. So you have your NH3 gets, is in your tubules, crosses across in the medulla, gets to the distal portion of the nephron, binds with the hydrogen in the distal convoluted tubule, and now you have a positive charge. Binds and ends up binding with your chloride, and then we end up measuring the chloride as opposed to measuring the ammonia level. So I always ask Dan, like, why are we doing that instead of, we had the ability to measure ammonia, why did we pick chloride? And it was, the answer to me, and unless it changed, was that they're already using these electrolytes, so it was an easy surrogate and they didn't have to change anything. So you're using the chloride as a surrogate to see if the kidney is able to dump that hydrogen. So in this case, we got a positive. So clearly it's not the gut's fault, which is sad. That means it's the kidney's fault. And now we got to find out, why is it the kidney's fault? So most common is you're looking at, so genetic RTAs are super rare, but that's what you're thinking of, RTA. CKD and AKIs can do this too, especially if you're in full force of an AKI. And then you're looking at any sort of induced RTA. So did something happen that caused the RTA? And we're looking at a Fanconi's type picture. So I'm going to say it's probably going to be a proximal tubule, but that's my spiel. Did that answer your questions, or any questions about that?
I think that makes sense. Does anyone have any questions in the chat?
I think
I do not.
Josh was asking, not related to the RTA itself, but he was saying, I don't know what to think about blood gases anymore. Depending on who I ask, BVGs are either fantastical, easy to get tools, or the worst thing ever.
All right, so here's the punchline. If you can get an ABG is the gold standard, right? By far, no one's going to argue with you on that one. But it's been written about multiple times in critical care journals, and what they looked at is, if you're in a pinch and, you know, if you have someone who's on pressors or clamped down, or they're obese and it's really difficult to get that ABG, go ahead and get the VBG, because you're going to get a good chunk of your info, and I would say probably about 90% to make a decision, and then you can, you know, dive in a little bit deeper when you get a chance to do the ABG and so forth. But the pH is roughly going to be similar. The CO2 is going to be similar. The O2 is going to be off, and then your bicarbonate is going to be similar. So it's a great tool to use, but it's not the gold standard. Hopefully that makes more sense.
Right. So if you want to know about the oxygenation, of course, a BVG is not going to help you too much. Right. It's going to be an ABG. So a BVG is good to assess metabolic causes. Let's put it that way. Okay, so her urine gap was positive. The calculation is 6. Right. So the formula is sodium plus potassium minus chloride. So in her case was 6, which is positive. And Andy mentions a pretty good mnemonic, which negative is associated with the intestinal losses. So anything positive is kidney issues.
Hey, I'm just a nephrologist, man. I'm not that smart. I need to like come up with ideas to remember this stuff.
Okay, so any other questions? Anything else that you'd like to know?
So since we got this far, we know it's the kidney's fault. We don't know a baseline, but she's got a creatinine of 1.4. Did we ever measure her urine output? Like, is this diuresis, hypovolemia, like a portion of the hypovolemia from that, or is this, you know, why is her creatinine up? Like, that's what I'm trying to figure out. Like,
yeah, so of course she got fluids and then her creatinine normalized.
Okay.
We thought that the AKI was just maybe renal because she had this episode of diarrhea.
She had the hypotension. She was losing all her solids, all that. Yeah.
Right. Yeah. And her urine output, because she was in the ICU, was measured and she didn't have any polyuria.
Okay. So no medications, just a blip of diarrhea. Renal perfusion was reestablished, and she's got a Fanconi's picture. I mean, if we, and we did the spot, we did that.
I think the other interesting point will be how to approach this degree of hypophosphatemia. What's your approach when you see?
I've always asked for a fractional excretion just to make sure that it's renal wasting, and no one ever does it. So that's always really annoying. That's why I never asked for it. But that usually does help, because then you can tell if she's nutrition-wise eating appropriately and the kidney's just dumping everything, or if she's, we're dealing with this malnourishment kind of thing, even though we're looking at a Fanconi's. But
yeah, we did do the fractional excretion of phosphorus, the PFOS, and was pretty high. That's 90%. Yes.
Wow, I'm surprised. Was she ever on a vent?
No, that was the other surprising thing, because muscle paralysis can happen.
I am very impressed.
Yes.
Holy cow. All right.
Okay. So let me move my slides. Okay, so what's next? Trying to assess the causes of her, right? I think rheumatology can also try to help us if they think this way as well. So of course we send a autoimmune panel, right? Trying to look for causes on why she will have this Fanconi syndrome. So we did order C3, C4, which was normal. Her ANA was positive, was 1/1280. Her DSA DNA was negative. Her anti-Ro was positive above 8, and her LA antibody was positive as well, 3.5. The rest of her immunological panel was negative. So now she has pretty much Sjögren's, right?
Wow.
I don't know if rheumatology will think about any other marker or any other labs that you might ask.
Yeah, Sonia, feel free to unmute yourself if you're in a place where you can do that, but no worries if not.
I think the only thing we'd do is we'd confirm the diagnosis with either a salivary gland biopsy or a Schirmer's, because as Sjögren's antibody on its own, even in the context of a very highly positive ANA, without other findings of Sjögren's, is suggestive, but not necessarily diagnostic. So we'd probably want to clinch the diagnosis, but like with an RTA and a positive SSA and a positive ANA that's very highly positive and actual sicca symptoms, it sounds pretty gosh darn convincing, and we just want to confirm.
And that's what happened. She did have a biopsy, which confirmed the diagnosis of Sjögren's.
So Pablo, I'm just curious, did she get an SPEP? Was the protein gap, was that polyclonal?
I don't think so. I don't have the number here, but I don't think so. No, I don't think she did.
So what these labs were drawn when she came in with when she came into the ED, right? Like the protein gap. Was she hemoconcentrated then because she was orthostatic? So that can explain why her total
exactly.
Yeah.
Exactly. That's why we didn't pursue the paraproteinemia workup, because that normalized after hyperfluence, which is very common to see, right? Dehydration causes this elevated protein gap, and also sometimes even hypercalcemia. So we like to hydrate the patients, and then if that's persistently positive, to do the workup.
All right. Wow, this is kind of...
Yes. So at that, when we thought about the diagnosis, we started to give her potassium citrate, also sodium citrate, and of course we call rheumatology for the salivary gland biopsy, which she actually did have, and showed this diagnosis. She was started on MMF. If I'm not wrong, let me open this.
I just want to comment on Dr. Center. Like, thank you for doing that look, because I was always under the impression that Sjögren's causes a distal, like a lot of the autoimmune stuff. So apparently there have been some reports of Fanconi's with it. Interesting.
That's right. So we couldn't, of course, what you're saying is totally right? But we went into the literature and we found that proximal can be caused as well. Wow. By Sjögren's. It all depends on the extension of the disease.
Yeah, no, but this is good because I was so fixated on the proximal tubule that I just eliminated, you know, the rheumatologic components. And I guess I did my own faux pas where I just kind of like mildly ignored the Sika syndrome, but I'm really happy that Dr. Sender brought this up. This is great. So I definitely want to take a look at that. But this is really interesting.
I'm trying to find out what she's currently taking for the Sjögren's. So give me a couple minutes.
The great mimickers of Rome. I love that quote. This is great.
And Pablo, thank you so much for bringing another fantastic case. I've learned so much from your cases. Would either Pablo or Andy, would y'all just summarize kind of what, just to make sure that we all have it, like what are kind of some of the things that, even though it's a rare diagnosis, that should clue us into an RTA and especially a proximal RTA?
Right. So, oh, sorry.
Could you just rephrase that?
Yeah, just kind of a summary of what things should clue us into an RTA, and then specifically what things to be looking for in a proximal RTA.
I mean, Pablo, do you want to take this? You want me to do it?
Yeah, so hypophosphatemia, hypokalemia, right? And the most, I think, reliable test for me to say, you know, this is probably Fanconi's and proximal is glucosuria in the absence of hyperglycemia. But just make sure that the
SGLT2 inhibitor.
That's what I was going to say, that because we are now using those so much, and I think everyone should use it. I think it's the best drugs for the kids and for the heart, so use them. But yeah, make sure that your patient is not taking a SGLT2 inhibitor. She was not. So every time you have glucosuria with normal glucose in the blood, that will lead you into Fanconi's, right? Of course, do a urine gap to in the setting of non-NGAP metabolic acidosis to see if you're going to have positive. It's going to be positive or negative, and see where the problem is, right? The other thing that helps a lot, as Dr. Kowalski was saying, is a uric acid. If you have a low uric acid, it's also going to help your diagnosis of proximal RTA. And also, if you are losing some proteins like the beta 2 microglobulin, is going to lead you to the diagnosis of RTA, of proximal RTA.
And just piggybacking off of Pablo, some quick pearls to just think about too. And these might come up in clinical practice. This might come up in, you know, on exams too, whether it's, you know, USMLE, ABIM, whatever. But a lot of times you can get confused between a proximal RTA and a distal RTA based on timing. So in a distal RTA, your urine tends to be more alkaline just because you're not able to acidify it. So one of the things that tend to happen, and I guess if I take a step back, when we talk about, you know, stones per se, so the way we treat urine stones is we tend to alkalize the urine. But 1 stone tends to be a little bit more prominent in a alkaline urine, and that is calcium phosphate stones. Calcium oxalate can also, but calcium phosphate. So in a type 1 RTA or a distal RTA, you're typically going to see nephrolithiasis happen. Now, depending on when you catch a type 2, you're dumping that bicarbonate. So you're not recycling the bicarbonate, whether it's a genetic issue with the carbonic anhydrase or you just have complete dysfunction of the proximal tubule. So when you check initially the urine pH, it's going to be elevated. It's not going to drop. And then once you start eliminating more bicarb, the pH starts to drop. So that's where you can get your differentiation. So initially a type 2 will have an alkaline urine and might mimic a type 1 depending when you catch it. 2, because you're not recycling the bicarb, you get a little bit of bicarb recycling towards the distal end of the nephron, the distal convoluted tubule, but you're really chasing your tail in terms of bicarbonate repletion in type 2. So that becomes annoying. In type 1, you're still able to recycle the bicarb. You just can't acidify. So all you have to do is just get enough to neutralize the acidosis and you should be okay. And then you got that weird type 4 that everyone tends to forget, but always talks about with diabetes, which is a hyporenin hypoaldo. So that is the best quote I have ever seen. I love it. Somebody on rounds 2 weeks ago called me the king of beans and I could not stop laughing.
Alexander Smith is asking about the phosphate repletion. So yeah, he got a central line and we did replace his phosphorus, and in the meanwhile he was getting the treatment for the Sjögren's. And then after discharge, we're still seeing her in clinic and her electrolytes are within normal limits now.
Nice.
Would it be okay if I just reminded people how dangerous hypophosphatemia is?
Please do.
So there are 5 ways that you can get really seriously ill or even die from hypophosphatemia. And I've seen it happen once. And the way to remember it is the brain can be involved. It's anything that uses ATP. So you can either get seizures and or altered mental status. The heart, you can get exacerbation of heart failure because the myocardium doesn't squeezes, and you can get VFib. And we had a patient die of VFib a number of years ago who came in with a phosphate of 0.7. You can get respiratory failure because you need muscles to breathe. So we have heart, lung, brain. Then we have hemolysis that can occur because you need it for the membranes, and white cells don't function, so they get infections. So that's the hematological system. And the last thing, and of course the most important, is you can get rhabdo and get acute renal failure. So all of those can happen with severe hypophosphatemia. That's why I said in the chat that I'm much more worried about a phosphate that I can't measure than potassium at 2.8. Potassium at 2.8 is very interesting, but it rarely gets you in big trouble.
Dr. Center, can I ask you something? Because I see this very often on DKAs, that nephrology is the one that is worried about the phosphorus. And I see that usually when people are admitted with DKAs, they don't have a phosphorus. Do you see this oftenly? Are you concerned of hypophosphatemia and DKA?
Absolutely. And it usually doesn't show up till the 2nd or 3rd day. If you remember from pediatrics, the pediatricians treat all the people with DKA with K-phos because they're just anticipating there's going to be phosphate depletion. We don't do as good a job in that. And we see it in DKA, but we don't see a lot of DKA where I practice. We do see a lot of hypophosphatemia in people who have a primary alcohol diet rather than a food diet. And again, once you start feeding them, there are 2 reasons not to quickly feed someone who has an alcohol diet. There's hypophosphatemia and thiamine, and so you have to worry about both of those. So I think checking phosphate on day 2 and 3 in someone who's cachectic who is now eating is really dangerous because it's refeeding syndrome.
Yes,
No,
we always tell the residents to check phosphorus on DKA because I don't know why it's not under the panel and they don't think about it. And yes.
Hey Pablo, did that happen at at your old institution? Because I very rarely get put on any sort of DKA case. I was just wondering if they checked phos routinely then.
No.
Really?
No.
Huh.
And where they did my residency, we like the panel was to check phos and mag even, but here I don't know why we don't. The phosphorus not under the panel. Yeah.
I feel like refeeding syndrome tends to be forgotten so often because I guess we don't think of that being prevalent in it or being seen in a developed country, but it does show up.
Just have to see one person die, but you'll never forget it again.
Oh, I bet. Thanks for the reminder. That was a great breakdown.
Thank you all so much for an amazing case. Pablo, Andy, and then Sonia and Dr. Centaur for coming in with some insights. We have learned so much. Any last thoughts before we have Chiara wrap us up with teaching points?
Everyone should go into nephrology.
The beans are cool.
The beans.
Hashtag bean team.
I love it.
Chiara, let's take us away.
Hey, amazing case as always. I have to confess that I have nephrophobia. But after today, I feel like it's a little less neprophobic. So just to summarize, we had a patient with refractory treatment for hypokalemia and hypophosphatemia. So this patient was a middle-aged patient who also had dry mouth. So our first approach was that when we have a patient with dry mouth, we have to think about common things like weather conditions, or maybe that this patient is taking some diuretics. Also, we have to think about some autoimmune diseases like Sjögren. And also Sonia told us that we would have, if we want to confirm or approach that this is it is really related with a disease, maybe we have to check the teeth and the eyes with a Schremer test. Then we also had the chemistry, and this patient had severe hypokalemia. So there is a condition called periodic paralysis where there is affected the potassium channels. So we can see this patient because this patient can have an intense response to insulin. It is usually, or it can be genetic and presents as in this page, like in the 20s or 30s with multiple episodes. And it is associated with carbohydrate meals or extreme exercises. Then when we have a refractory hypokalemia treatment, we have to think about problems. We have to think about the probability of being losing potassium or other serious complications. Like Uncle Bob said that he was really concerned of hypophosphatemia more than hypokalemia. Also, one amazing thing that I forgot, but thanks for today, I really remembered, is that when we have a urine anion gap, we have to interpret it as the kidney is able to secrete acid. And why we measure chloride? Because chloride is excreted with ammonium. So the real thing we want to know if there is if the ammonium is really excreted. So if we have a negative urine anion gap, we have to think about GI problems or maybe a proximal RTA. And if we have a positive urine anion gap, we can think about any other RTAs like type 1, 3, and 4. So thank you so much for the case, Pablo, Andrew, and Marie, Sonia. It was an amazing case and very educational one.
Awesome.
You're muted again.
Good night,
Thanks again.
Thank you.